Okay, hi everyone. Again, this is the second part of our webinar. Myself, Majdi Hamashi, President of PAMA, and Rami Al-Ahmad. He is the chair of the Education Committee of PAMA. I'm a critical care attending, and he is a faculty at Yale Hospital and School of Medicine, and he is a hospitalist, and we are both on the front line of treating patients with COVID-19, and we're trying to share our experience kind of in a practical way related to inpatient management of COVID-19 patients. So Rami, in the first part, if you did not listen to it, go and find it in our YouTube and social media. He talked about inpatient management on the floor, and now this section I'll be talking about inpatient management in the ICU for those patients who get sicker and end up in the ICU. And quickly, the numbers are like about 80% of patients have mild disease and they don't go to the hospital. 20% go to the hospital. About 15% are on the floor, and 5% go to the ICU. So I deal with those patients who end up in the ICU. Rami will be asking questions. This is a recorded webinar. And he will be representing the audience with the questions. Okay, Rami?
Okay.
So basically, for ICU management, we have supportive care and we have also specific therapies. In the first part of this talk, we went over COVID-19 targeted therapy, and we discussed the evidence behind it and the guidelines related to it. But in this section, I will be talking about supportive care, basically for ARDS and patients who have respiratory failure from COVID-19. So this is a very, I think, important algorithm, you call it, for escalation of oxygenation in COVID-19 patients. So our target is to keep their oxygen saturation by pulse oximetry more than 90%. If their saturation drops below 90%, we need to start providing oxygen to these patients. And they are not like other patients. So we have to be careful about the spread of the disease when we add supportive care. So, and that's going to clarify itself in a second. So we start with nasal cannula, 1 to 8 liters per minute. As long as you can use the nasal cannula, please use it. But if the oxygen saturation continues to be below 90 or drops to below 90, or the patient work of breathing is worsening, then you need to escalate care from nasal cannula to non-humidified oxygen mask, or oxymask we call it, or Venturi mask. And it's important to notice it's non-humidified. So we're trying to minimize aerosolization. We do want to make the oxymask an aerosol generating device. So we're going to use it as a dry, just oxygen from the wall without humidification. And we're going to use the lowest flow we can. So we start with 9 liters per minute, and you dial up the FiO2 to the highest you can, 50%. And so, but if the 9 liters is not doing it, then you increase the flow to 12 liters. If using oxymask did not do the job and patient still hypoxic, then you're going to go to non-rebreather mask. But if you reach to the point of non-rebreather mask, which generally provides about 90% oxygen, and non-rebreather masks are those masks that are attached to a bag and that inflates and deflates as the patient breathes. Those reservoirs provide about 90% to 100% oxygen. So the patient reached to that point and you escalated therapy according to that algorithm, that means your patient is very, very sick. Think about it. If the oxygen saturation below 90%, that means the PO2 is below 60 or below 70. And you're already using more than 90% FiO2. So the PF ratio is already below 100. So that's a severe ARDS just by using NRB. So at that point, once you use that point, you reach that point, you need to move your patient to the ICU if that's available, and that's according to resources in each hospital, or a COVID-specific unit, or a step down. You need to escalate care. So you move the patient to that higher level of care, and you're gonna do one of two things. If you can use the non-rebreather mask and the saturation is above 90%, you're good. Just we're gonna stay there. But if the patient continues to worsen despite using non-rebreather mask, then you're gonna do one of two things, depending if you have a negative pressure room or you didn't have a negative pressure room. If you didn't have a negative pressure room, then you cannot use the high flow or the non-invasive positive pressure ventilation, because these are aerosol generating procedure. We can debate the high flow, is it or it's not. Literature is varying on that, but most people are concerned using high flow above 30 liters, high flow oxygen, which is like in the US we call it, like, I don't want to call brand names, but it's a high flow. It's not like the nasal cannula. You drive the flow up to 50 and 60 and 70 liters. At that high flow, there might be some aerosol generation. So we are concerned. So we prefer using high flow or non-invasive positive pressure ventilation in a negative pressure room. So if the negative pressure room is not available, then you need to intubate the patient. Call whoever intubate that patient in your hospital to intubate the patient. If you have a negative pressure room, then you have some room to use the high flow nasal cannula or non-invasive positive pressure ventilation, or use them one after the other. So you start with the high flow, then escalate to non-invasive positive pressure ventilation. But if you use these, if you use the high flow, make sure to apply a surgical mask on the patient on top of the high flow, and also limit the flow to 30 liters per minute. If you use a non-invasive or BiPAP or CPAP, we're gonna use a viral filter, and I'll show the picture of that viral filter in a few slides. And if we use also BiPAP, EVAP, we want to ensure that the mask fit well around the patient, because we want to minimize the leak around the mask. So those are initially, like, some data came out that we should not use BiPAP on. Well, I will use it if I have a negative pressure room, because I might avoid intubation, and we have successfully avoided intubation in some patients who might also be COPD patients, and BiPAP will work very well as long as we are not exposing healthcare workers to that to the virus by aerosolizing the virus. So keeping patient in negative pressure room should be okay.
Majdi, let me ask you a question. We've been seeing a subset of patients who are hypoxic, and their numbers actually, like, the pulse ox in the 80s, but like when you look at them clinically, they're like they're not bad. Like, they're not like in severe distress as we see in other diseases like CHF or like flash pulmonary edema. We put a non-rebreather mask, and then they they do well. So in this people, would you continue to watch them on a non-breather, or you upgrade to either high flow versus or like a non-invasive?
So what you're referring to is what has been called silent
hypoxia.
Patients, and basically what's happening, patients walking in the ED and they measure their oxygen saturation like 70 and the PO2 is 14, but they're talking to you, and that's an interesting finding. And I think that happens when the lung is not heavily involved in the disease. I mean compliance-wise, the VQ mismatch is a problem, but the lung is not stiff and still compliant, so the patient work breathing is not high. So the patient is not feeling much of the dyspnea, and they are having that silent hypoxemia. Should we do permissive hypoxia in those patients? And I've seen some doing the awake proning. I have nothing against awake proning, and I will try it on my patients as long as they are tolerating it and it's done safely. So, but should we do permissive hypoxia? I'm not sure. The SCCM guidelines were very clear from previous data and literature in ARDS. Even 88% has been harmful compared to 90%. So the SCCM made a strong recommendation about 90%. And actually they wanted it to be 92, and they recommended, with a weak recommendation, 92 to 96, the oxygen saturation, and a strong recommendation to make it 90 to 96. They do want a patient to go hyperoxic, and they say do not oxygenate above 96%, but don't let the oxygen drop below 90%. So I went with the SCCM guidelines, knowing the literature we have, but are COVID patients going to be different? Are they going to teach us that to do permissive hypoxia from now on? I don't know. We need to remember that oxygen is important because it's part of that formula of oxygen delivery, and oxygen delivery to the tissues is what matters. If oxygen delivery is decreasing, then the tissues are not perfused, and we have what we call shock with lactic acidosis. Now, if the patient is healthy and has a healthy heart, and they have a normal hemoglobin, they can tolerate low oxygen level because the cardiac output will compensate for that low oxygen content. So the oxygen content is low, but oxygen delivery is normal because they compensate. And if you do echo on them, their cardiac output is higher than their own baseline. So, and also assuming they're having normal or decent hemoglobin level, they can live with the PO2 of 40. They can be okay, and they will not be having lactic acidosis. And you will not see that dyspnea or cosmal breathing we usually see in patients who are hypoxic, because those patients have normal oxygen delivery. So what I'm trying to say, you might tolerate hypoxia, permissive hypoxia, as long as you know oxygen delivery is not impaired and the patient can maintain such high cardiac output for a long time. But as if we go by the guidelines, we're keeping now oxygen saturation to be 90% or above, but not higher than. Okay. So that's how you escalate oxygen treatment, and that's when you decide to intubate based if you don't have negative pressure room, then after non-rebreather mask you intubate. If you have it, you might try high flow nasal cannula or BiPAP. This is basically how to escalate oxygenation. So you escalate safely. What I mean by that, you do want to end up with hyperoxia, and also you do want to keep the patient on nasal cannula when they need oxy mask now or non-breather. So you need to be responsive to patients' needs, and you need to allocate patient to the ICU early, which is you should not keep patients with non-breather mask and barely oxygenating. You do want to keep them on the floor because they are getting worse. And also we're going to always avoid aerosol generating procedures outside negative pressure rooms. So that includes nebulizers, high flow nasal cannula, non-invasive positive pressure ventilation, sputum induction. We do want to give those patients an incentive spirometry, which we love and we always give to our patients. We do want to give it to those patients because we do want them to be coughing a lot. And also other like, pulmonary hygiene, like flutter valve and all these devices. We do want to give it to those patients. And now that's the question you asked, should we tolerate hypoxemia? So it goes back to oxygen delivery.
Yeah, if I want to make a point, it's kind of like a deal mainly with people on the medical floor that I think the healthcare worker from the nursing staff, physicians, and everyone else that they should be aware that once the patient gets into the hypoxia level, that they should act quickly and involve the ICU team as soon as possible, because we've seen cases that they really crash in a very dramatic way. So that the sooner they react and relocate the patient and involve the ICU, I think that would be better.
I totally agree with you. Just to give you an example, in my last shift, I saw a patient who is D and I, do not intubate, but he's okay with using the PiPAP. But that patient was outside a negative pressure room, and that ICU has only one negative pressure room. So we made sure that patient to be moved to a negative pressure room should we need PiPAP, because he was already on non-rebreather mask. So he's heading in that direction. And surely he required the PiPAP like a few hours later. So that's important. So you need to be proactive, be ahead of the game, and move your patients to where they need to be, because you don't want a patient crash on the floor when the team is not prepared to intubate or resuscitate that patient.
Yep.
So this is when to move the patient to the ICU. So that's kind of a nice segue. So if you need a non-rebreather mask to keep their oxygenation, if you there's a rapid escalation of oxygen requirement. You like in few hours you're jumping from nasal cannula to oxymask to non-rebreather. So that means they are getting worse quickly. Also, if you have a significant work of breathing at any oxygen level, hemodynamic instability, we all know that. Acidemia is very risky. If you remember, we talked about that oxygen delivery formula, which is the cardiac output times the oxygen content. And oxygen content has to do with the hemoglobin and the PO2 in the blood and the SpO2. So if the patient is maintaining their oxygen delivery, they are not acidemic. But if they started to be acidemic, that means the heart is not keeping up with the demand anymore, and they started to reach that point of critical hypoxia. So at that point, definitely the patient needs to be moved to the ICU. And also, if you have severe comorbid illness and high risk for deterioration, those patients who are old, have hypertension, COPD, immunocompromised, you need to be proactive in those patients. I've skipped one. Intubation precautions. So this is very important. So in the ICU, we deal with this a lot because those patients who come to us, we intubate them, especially if we don't have a negative pressure room. So few items here, and those anesthesia doctors or critical care doctors who see this list, they're gonna quickly figure out what we're talking about. So we need to limit personnel in the room. So the minimal amount of people or number of people who will get the job done. So we don't want to expose them to this high risk procedure. You are manipulating the airway, and if the patient coughs while you're intubating them, you're going to aerosolize all those pulmonary deep secretions into the room. So it's a highly contagious atmosphere. So you want to limit the personnel in the room. All staff should don full protective gear, which is N95, the eye shields, the mask, the head cover, the gown, and all that. Airway team, if possible. Some hospitals started to create airway team, which is made of the anesthesia doctor, the RT, and the nurse, and they move from room to room to intubate patients. And they know what they're doing. They do it the same thing, the same way every time. So they get that kind of a protocolized approach to patients. Also, we use non-rebreather to pre-oxygenate patients. Ideally, when we intubate patients, we use the amble bag to bag the patient while we're waiting for anesthesia medications and induction and all that. We do want to use bag valve mask ventilation in those patients because that bagging process is an aerosol generating procedure. We don't want to do that. And also, we apply viral filters wherever we can. If we use a mask, or if we after we connect the ET tube, so we need to get that viral filter quickly there. Apply surgical mask on the patient. So if you are using non-rebreather mask or high flow to oxygenate them, well, put a surgical mask on top of that. Video laryngoscopy. So that's not the time to visualize the airway the old-fashioned using a Mac or a Miller. You want to increase success rate from the first attempt because you want to minimize the exposure to the virus. So, and also most experienced staff with intubation, not necessarily the most senior. We know in academic hospitals, senior attendings, they might not have intubated the patient in a year, but the fellows, they do that day and night. Having that said, you should not let the fellow go by themselves. You should go with them. But the fellow should be the one who is intubating if they have more hands-on than the attending. So not necessarily the most senior, what I'm trying to say. RSI, so rapid sequence induction and intubation. So in my ICU where I work, I don't necessarily use RSI all the time. So I make use of the patient effort to keep breathing on their own while I'm sedating them and intubating them. But in this situation, you do want the patient to cough, and you want a better success rate from the first attempt. So definitely you want to use rapid sequence induction intubation. Negative pressure room if available. So this is not like some hospitals, they have only one negative pressure room in their ICU. So you cannot accommodate that all the time. Any questions on this list, Rami?
No, yeah, we've been, the anesthesia team in my hospital have been, yeah, just kind of like almost, going through this list, and they're like really heavily equipped. Like when they go into the room, it's got like it's almost 3 layers of protection, which give you like really a hint how much exposure they're like really at risk of doing it. Hopefully not. You have to then deal with intubation.
Definitely. You are in the lung, like you are where the virus is.
Yeah.
So this is a setup I like to show, and I showed our RT in our hospital how to do it. And I got this from, I mean, I keep referencing the guidelines down at the screen, but this one I should have put the reference of the, mcret.org, that internal emergency medicine care website, very useful website, and I encourage people to visit it. I do myself. So they put that together. So this is a bag valve mask, and if you want to use it without squeezing the bag itself, that green part, if you don't squeeze, then it's not an aerosol generating device. So what you do, you hold that mask tight around the patient nose and mouth, and you run oxygen flow where it says that wall oxygen 15 liters. You run it at 15 liters, and also you run another oxygen in that post stem. There's another like oxygen connectors, you see that tubing where it says 6 liters per minute post stem oxygen. So this one you run it at 6 liters, and the other one you run at 15 liters, and you just hold the mask tight, and this will inflate the lung. It will create a CPAP phenomena, and the patient will be oxygenated, and that can also be used during code situations. We're going to talk about code when it is CPR only code, and you don't want to bag the patient, but you hold that mask tight with the oxygen flowing at 15 from the wall and at 6 with the post stem connection there. And also note the PEEP valve. You want to dial the PEEP valve to 15 centimeters water, and you want to use the viral filter, and the viral filter should be close to the patient as much as you can. So in this case, just after the mask. So that's a nice setup. It should be ready in all COVID patient rooms who might be intubated. And even whenever, like they have a high re-intubation rate more than other patients. So even when you extubate them, you should be always ready with this setup. So this is intubation. Very useful, and very easy to replicate wherever you are. And definitely it will decrease the exposure of the provider who is intubating the patient to the virus. So I like the setup here, so the hands can move up and down a little bit. There's a room, so you can move your video laryngoscope as you need, and the provider is protected, and it's fully transparent, so you can see the camera of the video laryngoscope. So I'm going to talk about ARDS vent management. So again, this talk is to internal medicine doctors who are going to end up working in the ICU because of the surge in their area, or critical care doctors that don't deal with severe ARDS often. So to provide kind of an algorithm, or what do we do in a stepwise fashion. So again, lung protective strategy, we know the ARMA trial, and that's 2000, and that's 1-year-old knowledge that we should always use lung protective ventilation, which is 6 ml per kg. Having that said, we don't start with 6 ml. We always start with 8 ml, and then you walk your way down to 6 ml if you need. And you need to keep the driving pressure, which is the plateau minus PEEP, to around 15. If your driving pressure is 10, you don't have necessarily to decrease the tidal volume from 8 to 6. I mean, you look at the compliance of the lung, and there has been data that the ARDS in COVID-19 patients is like 2 types. There is the ground glass type, which is very compliant, which they are very PEEP responsive, and they don't need much PEEP. So you don't have to go with the high PEEP strategy here. You just look at the driving pressure of PEEP, and you don't have to go very low on the tidal volume. But also there is the consolidation type, whereas classic ARDS and the lung is stiff, then definitely you need to watch your driving pressure and plateau pressure, keep them below 15 and 30 respectively, and you might need to go down to 6 ml per kg on the tidal volume. Again, permissive hypercarbia we do in ARDS, And in my institution, we tolerate pH as low as 7.15. And we add bicarb if it goes below 7.15. And also we use the ARDS tables to guide FiO2 and PEEP titration, because you don't want your patient end up on 100% oxygen while they are on PEEP of 5 or 8. You need to increase the PEEP accordingly to their need. There are in ARDSNet FiO2 PEEP tables, there's a high PEEP and low PEEP. Again, if you are dealing with a very stiff lung, you want to go with the high PEEP strategy. If you are dealing with a compliant lung, you might want to go with the low PEEP strategy. So recruitment maneuvers, definitely you want to use recruitment maneuvers in a stiff lung when you're already using the high PEEP strategy, patient is hypoxic. So what we do, basically, we go, there's two ways to do recruitment maneuvers. There's like a staircase approach, which we don't like. And the one I use is you dial up the CPAP to 35 for 35 to 40 seconds. So I do 35, 35. So CPAP up to 35 centimeter water, keep it there for 35 seconds. And then go back to a PEEP at a higher level than the baseline. If they were on PEEP of 16, I go back to PEEP of 18. So to keep the lung recruitment there, not to lose it again. So what I'm trying to say, lung protective strategy, permissive hypercapnia, and the PEEP tables, low PEEP or high PEEP strategy, and recruitment maneuvers. That's kind of basic stuff for ARDS. So the fluid strategy, you talked about that, Rami. So we know the FACT trial taught us a lot about conservative fluid approach in ARDS patients. We like them as long as they are not in shock, they are not on pressors. We like them to be on the negative side, fluid balance wise. So even we diurese them. I like to diurese those patients as much as I can. If they are on CRRT or dialysis, I talk to the nephrologist. We need to achieve a negative fluid balance. So if you want to give fluid boluses, try not to do it unless they are in shock. And not all patients in shock need fluid. So they can be fluid responsive, they can be fluid non-responsive. And lately, in the last decade, most intensivists moved from the static hemodynamic measures to dynamic hemodynamic measures. So we rely more on pulse pressure variation, stroke volume variation, point of care ultrasound, passive leg raising test, and fluid challenge. So these are like, they need a talk by themselves, but basically we don't use CPP. That's what I'm trying to say. We use dynamic measures to guide fluid therapy. And fluid challenge might be the most useful one. So that's the easiest one to do. Give a 250 fluid over 15 minutes, quickly push it in, and don't do anything else meanwhile. Do not increase sedation, do not increase PEEP, do not do anything. And monitor pressor use. If the nurse told you I came down on norepinephrine, then you know that patient is fluid responsive and you can give more fluid.
All right.
This one.
Yeah, go ahead. I'll go ask the question after this slide.
Sure. So now if you did everything before and your patient still hypoxic, which I mean like PO2 50 and SpO2 or pulse ox like low 80s, and you don't know what to do, so I need to do more. Then that, and you are dealing with a PF ratio below 100, severe ARDS, then that's not the kind of patient you want to keep them awake. We like light sedation in ICUs, but not for this patient. This is refractory hypoxemia at this point. If you are using PEEP of 12 or more, FiO2 of 80%, 90%, 100%, and your PO2 is below 100, then you are dealing with severe ARDS and PF ratio below 100. That patient should be deeply sedated. Whatever your sedation algorithm in your ICU, we use analgo sedation in our ICUs, which means we use opioid as a first line, then we add a second line agent, propofol or Precedex. We try to avoid benzodiazepines, but in COVID-19 patients, I've been using benzodiazepines because hypertriglyceridemia has been an issue, and we need to cut down on the propofol, and I need an alternative agent. So lorazepam, boluses, and infusion has been used. So if you've done deep sedation, patient still hypoxic, then you need to start thinking about proning your patient. We know that the Brozeva trial showed that proning helps patients improve mortality, and that's evidence-based. So we prone our patients in the ICU, manual proning, or if you have mostly manual proning. But we do have rotor prones here in the US. So, but manual proning for 12 to 16 hours per day, and different hospitals with different criteria for proning. You can use, like the Prozeba trial was done PF ratio below 150, but we prone below 120 in our institution. So, and if you're using people 14 or more. So basically, prone early. Do not wait for a long time, and within 48 hours. While proning is good, might not be necessarily the best thing to do if the team in the ICU you're working in is not familiar with proning. So you do want an unexperienced team proning a very sick patient, because proning helps in evidence phase, but they don't know how to prone the patient, because those patients can easily go into cardiac arrest. If the tube kinks, or if the tube dislodge, or they get extubated, they have no room on their oxygen, and they're gonna quickly go into cardiac arrest, and if that, they will die. So the team has to be very well prepared, experienced, they know what they're doing before they think about proning a patient. Excuse me. So then the next step, and that also might go hand in hand with proning, is a neuromuscular blockade. The landmark trial is a cure assist trial, but there has been more studies lately, including the ROSE trial, that kind of trying to negate the benefit from neuromuscular blockade, but we still use it if we need it. And you might do it in boluses if you can go with that, but if you need an infusion, you start an infusion. Most patients who need proning, they need neuromuscular blockade, and we try to limit neuromuscular blockade to 48 hours because of the critical illness, neuromyopathy, and all these concerns. But if you need to do that, you need to do it. This will increase synchrony, patient-vent synchrony. It will decrease the oxygen demand in non-vital tissues, and will help the patient lung mechanics to go through that high kind of aggressive ventilator strategy. Then if you have proned your patient, deeply sedated, paralyzed, and still hypoxic, you might try pulmonary vasodilators. We use the like Flolan in our hospital. We do not use nitric oxide, given the kidney injury concerns, and they both do not improve survival. We know that. But Flolan improves oxygenation, so I'll take that. So we use it, but not all hospitals have Flolan. And lastly, you might think about ECMO, but most hospitals are being careful. You don't want to open that can of worms, and ECMO should be only offered if the patient is going to go through the ECMO and survive. So so you need to be very selective when you want to offer ECMO to patients.
All right, interesting points. And my question is, from your experience so far, have you noticed any difference in the clinical behavior for COVID patients compared to like the ARDS that we usually see in like let's say septic shock or pancreatitis?
Well, I tell you, lung mechanics, they are the same. They have both stiff lungs, and we had to use high PEEP strategy. Like the ones we had, they have kind of the diffuse infiltrate and with consolidation, and the lungs were stiff in the last two patients I'm taking care of. And we have to use high PEEP strategy, and APRV as a salvage mode has been also used. They don't get better easily. They stay on the vent for a long time, like 10 days, 14 days on high vent settings. I have seen ARDS improve faster in other diseases, including influenza, pneumonia. We prone patients like for a couple of days, they go back to supine, a couple of more days, they are extubated, and 5-7 days total, we're done. This is kind of a when patients get sick with it, they are really sick, and
Yeah.
they don't get better easily.
Mm-hmm. Okay.
Yeah. But again, it's a spectrum of disease. This is how I look at it. That's why 80% go home. Like the other 20%, only 5% go to the ICU. The others stay on the floor. And those who go to the ICU, they are not all, like the intubation rate is high, 70% or so. But it's a spectrum of disease. The spectrum of illness, I mean, like the severity has a spectrum more than black and white. Okay, so that's also a very important topic. I think these are the last 3 slides in this discussion. So cardiac arrest, what if a COVID-19 patient had a cardiac arrest? What do you do? So, sorry. So basically you wanna limit the staff, the code team to the minimum. And we always say in any code situation, please, those who don't have job or not doing anything, leave the room, because we wanna clear communication between team members during CPR. So, but as you mentioned before, discussing goals of care with the family should be done before patient's code. So, especially the ones you think they're not gonna make it. So you need to clarify code status. If you can avoid it, that would be great, because you don't want the family telling you 10 minutes after the code, no, stop. But you could have talked to them before that. But those 10 minutes have exposed, I don't know how many team members to the virus. So, and also code situation it associated with, like, we are rushing in the room and we tend to do mistakes. We tend not to follow protective equipment like precautions carefully, because we want to save a life. We are just running, putting things quickly, trying to get to the patient as fast as we can. We end up compromising on the like the full gear, and sadly enough, very small percentage of patients make it, even if we rush fast to them. So I want to say that take your time. Don't be late to the patient, but you need to take care of yourself and the team members. Put all protective gear as fast as you can, but don't rush it. And then get to the patient when you can. So use PPE. Also place surgical mask on the patient and drape patient chest if you can. So that's very important. And minimize personnel. Use an automated compression device. I don't know, they might have it in Palestine or Jordan. Lucas device, we use it here, and that's gonna minimize exposure of the staff, the contact exposure, and so that device can do the job nicely. Also prepare ready-to-use code bags. You don't want to be calling for medications and pharmacy running in and out. So all carts should be prepared with code-related medications. And until a definitive airway is obtained, this code should be compression-only CPR. What I mean, no bagging. You don't want to be bagging your patient. What you can do with the non-rebreather mask and put a surgical mask on top of it, or if your patient is really hypoxic and you think the hypoxia is causing the code, then you might do what we explained earlier, hold that mask with the oxygen flowing in from the wall and the post-stem connectors. So you try to create a CPAP physiology with the patient, but do not bag that patient. Once you get the tube in, you can start bagging. So the airway, prior to securing a definitive airway, oxygen should be, again, applied via non-rebreather mask or what I just described, the mask. Avoid bagging the patient. Also, you need to avoid BiPAP and high flow nasal cannula. If the patient has a shockable rhythm, shocking this patient out of that arrhythmia is the priority. You want to get the pulse back and you're done. You don't have to do chest compressions or anything. So you don't want to finish your cycle of CPR, then you shock them. No, just shock them as soon as you can. Also, if the patient does not have shockable rhythm, then you should give the airway a priority. In the usual ACLS protocol, we should not intubate our patient. We should do chest compression. The C has priority over the A. So we're not ABC anymore in ACLS algorithm. So we do the cardiac resuscitation, the CPR, and we keep bagging the patient in normal situations. And if we get the pulse back, then we intubate the patient, because we don't want to interrupt CPR while the anesthesia trying to obtain the visualization and get the tube down the airway. So we don't intubate, but in COVID-19 patients, intubating the patient should be a priority. So if they don't have a shockable rhythm that you need to shock them out of it, you just proceed with RSI and intubation as we described earlier. So if the patient, if the pause in chest compression is excessive, and you're trying to intubate the patient with RSI, but we have not done CPR for some time, then you need to stop trying to intubate the patient. If you cannot get it quickly in, just use an LMA or any other extraglottic airway device. And if you connect an LMA, you should always connect a viral filter to that LMA. Also use continuous capnography to monitor ventilation if possible. If PPE supplies are limited, anesthesia and those who are managing the airway should don higher level of PPE, while others just step away from the patient. So post-resuscitation care, again, you need to dispose or clean all equipment used during CPR. And after resuscitation has ended, adhere to, again, strict the doffing procedure. And you can go to CDC website. They have a nice card for donning and doffing of PPEs. Then after you achieve ROSC and the patient has made it, then you're going to do post resuscitation, post CPR care, including targeted temperature management. So to summarize, cardiac arrest patients, minimal stat, CPR only, do not bag, do not use PIBAB or AirVo or high flow. Try to use non-breather mask with a mask on top of it. If you have really to use a CPAP physiology as I described it. If you have a shockable rhythm, shock the patient as soon as you can. If the rhythm is not shockable, do not do chest compressions while you're waiting for ROSC. No, intubate the patient first. So intubation should have priority. And if you cannot intubate the patient from the first attempt, then you're going to put an LMA with a viral filter on it and resume chest compressions. And after you get ROSC back, it goes back to usual post-resuscitation care. I think that's going to be my last slide.
Thank you, Marji. Really great information for me as an internist, and I'm sure I'm going to deal with this kind of situation at some point dealing with COVID patients. I just have two quick questions for you. The first one is, how much of an evidence that we have in dealing with ICU patients with COVID that is based on an solid evidence versus, a common practice or, a guidelines from a medical society like the SCCM? Like, for example, compared to the experimental therapies we talked about, there is some trials, there's some ongoing. Do we have the same thing in ICU?
Yeah, ICU patients are being enrolled in studies. So you mean, for example, remdesivir, for example, are we doing that on ICU patients?
Yeah, and mainly for ventilation, management. Are they kind of trying to have something different for them, or is kind of the common practice?
Yeah, that's an interesting question. No, I'm not aware of any study that is going on to see if ARDS from COVID-19 is different than other etiologies. So, and should we treat it differently? I think we're going to have some anecdotal evidence. Now, what is interesting, the SCCM, they are establishing a national registry, and they are many organizations are joining and many hospitals are joining. Basically, what they're going to do, they're going to collect data on COVID-19 patients, including ICU patients. So that's a Society of Critical Care Medicine. So they're going to heavily collect ICU-related data, and that's going to include ventilator settings. And I think we're going to learn a lot from that data in retrospect. So I think that's going to be enlightening, and that might lead to more studies in the future. You know, we know that COVID is going to come back in the fall and the spring of next year, and we hope there's going to be a vaccine by then, and so we can use it. But if there are studies that are going to be generated out of that retrospective data, I think that would be the time to use it in the future.
All right. And last question is, any for tracheostomy, is like any difference between COVID patient versus non-COVID, like kind of in terms of, you know, indication, duration, when we do it, when not to do it?
Well, now, like it's again, the way we practice in our hospital, we do the same thing, give it 14 days, and
Okay.
there's nothing magic about number 14 or 14 days. You can always extubate at day 18. If you think they need few more days, you can extend that time, and sometimes you might track them before 2 weeks. But I think most providers are avoiding tracheostomy in those patients as much as they can. And we tend to extend ventilation days beyond day 14, because think about it. This is a highly contagious procedure. You are messing with the airway. You are taking that patient to the OR, and you are placing a tracheostomy, and the trach is not as secure as the endotracheal tube. So those patients can aerosolize the virus more than patients with endotracheal tube. So that's a concern for the OR, for after the tracheostomy is done, for the staff and healthcare staff. So I think we should avoid it as much as we can. If we think the patient is going to make it, going to be extubated, I will wait a few more days to see if I can extubate that patient.
Okay. All right. Perfect.
Thank you, Rami. Thank you very much.
Thank you, Mr.
Sure. Take care.
Take care.